So this is the final section of this slide series. Today this is about prescribing in children and how things are slightly different when we're prescribing for children. So we've done the fetus, we've then done the breastfeeding babies. Now we're going to talk about children and the differences, the anatomical differences and the biophysiological profiles that are slightly different in children through the ages. And again, for everybody that's going to prescribe, you can only ever prescribe within your area of expertise and within your level of competence. But you all know that already by now. So this is just a quick recap on the Nurses and Midwifery Code 2015, which does suggest that we will only ever prescribe within our competence if we are suitably qualified. That we will always keep to the appropriate guidelines when giving advice on using any sort of types of supply or prescription of medications. That we make sure that all of our care and treatment is compatible with any of the other care and treatment that they're receiving, that the patients are receiving. That we always make sure that we store medications securely, and that wherever possible we avoid prescribing for ourselves or anybody with whom we might have a close personal relationship. And I think they're fundamental, really obvious issues that we're all going to adhere to from here on in, and we have done all the way through, hopefully. So we do have significant developmental differences when we're prescribing in paediatric settings. Again, we're going to look at the pharmacokinetic problems, the differences, so absorption, distribution, metabolism and excretion. Pharmacodynamic properties of drugs as well, and the actions that might differ across the age span in children. And we're going to look at a couple of equations just to see about dosage for treatment and effect. And in children we usually use milligrams per kilogram, so we use body weight to determine how much drug we should prescribe, or milligrams per meter square when we're determining things that are topical. Depending on which type of textbook you're using, there's a different sort of range of ages which are identified to define the parameters of which period that you're in with children and neonates. So preterm tends to be less than 36 weeks gestation. We know the limits of viability, sort of 23 weeks to 37, 38 weeks gestation. Full term is considered 37 to 38 weeks up to about 42 weeks of gestation. And normally by 42 weeks your baby will have been delivered, because that then becomes a little bit dangerous if you carry on with a pregnancy after 42 weeks gestation. The neonatal period is always identified as the first 28 days of life. And this is whether or not the baby's been born prematurely or to full term. So that's quite a movable sort of entity, the neonatal period. Infant is determined as 1 month to a year old. And again, that can change slightly up to sort of 1.5 years, depending on which textbook you're going to use. A child, 1.5 years to 12 years-ish. And an adolescent can be anything from over 12 years to 21, and I've just read some recent texts that are identifying adolescents as up to sort of 22, 23 years old. But it really does depend. But what we can say perhaps is adolescents, when you're thinking about prescribing for adolescents, over 12 years up until they're sort of around about the same height, weight as an adult, and then we're going to start looking at how we're going to prescribe for those as an adult instead of an adolescent. So I'm going to talk about the pharmacokinetics of childhood and prescribing in childhood and how that's going to affect things. So we're going to start with absorption, because we know the pharmacokinetics are associated with absorption, distribution, metabolism and excretion. So the first thing is absorption in childhood. There's a number of different things. So when you find in the neonate your gastric acidity, babies are born without any, with very limited hydrochloric acid around about 10 to 30 days post-birth. It doesn't help because they're also on a milk-based diet, so you're going to have quite, the gastric acidity is not going to be as acid, so the pH will be slightly different. Gastric pH at birth is around about 6 to 8, lowers within hours, and then it goes back to sort of 6 to 7 after 24 hours of age. It doesn't tend to reach adult levels until 1 to 2 years. Gastric emptying, again, this is going to be affected by the fact that neonates and infants have a predominantly liquid diet. So you're going to see irregular peristalsis, 6 to 8 hours for neonates. I don't know if anybody's had babies in this lecture so far, but I can definitely tell you that neonates tend to have lots and lots of dirty nappies, and that will change if they're on a diet which is breast milk or if they're on a diet which is the artificial milks. It'll also differ depending on what the mum's eaten at the time as well. So gastric emptying it doesn't really reach adult stage until around about sort of child age. GI motility, so gastric motility, that's going to be varied, and that depends on what type of food the babies are eating or the mums are eating if they're breastfeeding. You do find your neonates' pancreatic enzyme activity is decreased and doesn't reach full capacity until infant stage. Premature babies will have higher pHs for longer. Gastric emptying and gut motility is going to be affected by things like gastroesophageal reflux disease, reflux, diarrhea and vomiting, which are really common in these sorts of neonate, infant and children. So the one thing that you do find with neonates, infants and children is the acid and alkaline foods will alter your pH in your gastric system as well. So if you're trying to prescribe medications for your babies, your neonates and your infants, you're going to be thinking about what's there and how well they're going to absorb those medications depending on how acid and alkaline their guts are. The other thing as well that we need to identify as well is neonates. They are born, certainly, I mean, I used to look after premature babies, and you've got like a 24-weeker who can have skin that's, you know, sort of single cell thick. It's so permeable. So you have to be really, really careful about what you're doing. For example, if you wanted to clean skin and prep skin for a procedure, you wouldn't choose alcohol as a wipe because that will go through and the baby will absorb the alcohol through their skin. We know that you've got a thinner stratum corneum in infants and children as well. It's not necessarily as significant as it is in the neonatal period, but certainly you haven't got as much as much of that sort of the absorption going on. So you've got more of the absorption going on than you would have in normal circumstance in the adult sort of absorption. Okay, so distribution in childhood. So you'll find that total body water is increased in neonates, it's increased in infants as well, and doesn't reach that of an adult until they're children. You've always got increased extracellular fluid in children, so drugs which distribute to these places, like your aminoglycosides, for example, are going to be increased with the neonate and infants. Neonatal adipose tissue has significantly higher volumes of water as well, and this is really important because when neonates are born to start with, they have different sort of brown adipose layer, so they have a different type of fat which overlays most of the major organs to keep them warm, to keep that thermal neutral environment that they need to be able to grow and develop in the right way, and to sustain times of periods where they might not be growing as effectively. So you tend to find these places are slightly warmer than usual. So on the back of the neck and on the top of the chest, you'll find that these areas are slightly warmer in neonates than they are in an infant or a child. Your serum albumin in neonates is slightly lower, so they have a lower binding affinity for certain drugs. So neonates and infants alter plasma protein binding. This is really important for plasma binding drugs as well. We also see a lot of bilirubin and free fatty acids, which can be displacing drugs from sites that require protein binding. So for example, phenytoin, phenobarbital, furosemide. If you've got a jaundiced baby, for example, you're going to see a difference in how those drugs work in those types of neonates. Your blood-brain barrier is far more permeable in a neonate than it is in an infant and child. And if you ever look at, if you ever start sort of looking at the neonate, have a look, and the infant as well, have a look at how large the head is in proportion to the rest of the body. Get a child to sort of lift their arms up and you can see that the head almost fills the whole of the arm space. Whereas if you do that with a child and an adult, it's slightly different. So have a think about how big that brain and the blood-brain barrier is going to be in relation to the rest of the body, and understand that that's going to have an effect on how drugs are distributed around the blood-brain barrier. When you have a neonate as well, your perfusion, the blood flow and blood pressure regulatory systems are absolutely intrinsic to that sort of blood-brain barrier and how that's going to go as well. So, you know, you've got to think about how cellular membranes, changes in acid base and balance and cardiac output are going to affect your neonates to such a significant more effect than your infants and your children. So just know that blood pressure is regulated a lot by that composition, sort of between brain and rest of body. Fat contribution composition. Neonates will have 15 to 20% of their total body weight is lower than that sort of an adult as well. So that lipid soluble drugs are stored to a lesser degree. By the time they get to infants, you're looking at 21 to 26 total body weight. And when you get to a child, the most important thing here is to know that adolescent boys start to lose fat. So after the age of 12, adolescent boys will be starting to lose fat. They'll be reducing by around about 12% of total body weight, whereas girls will accumulate up to 25% of total body weight. This matters to girls and boys on an emotional level as well as a physical level, a physiological level. So it's well worth mentioning to adolescent girls that it is expected that they will accumulate 25% of total body weight as a fat composition. So when we're looking at metabolism, hepatic enzymes are reduced and slower metabolic rate than adults for neonates and infants, and then we sort of see a maturation of most systems by 2 to 4 years. Excretion. We do see renal blood flow is reduced in neonates and doesn't reach adult levels till around about 9 months of age. Glomerular filtration rate as well is decreased in a neonate, as opposed to when it gets to sort of around about 9, or when the baby gets to around about 9 months old, you're sort of back to normal levels and adult levels. So you can expect excretion to be on a par with an adult sort of levels. Renal tubular function as well is decreased in neonates, whereas it doesn't sort of get up to adult level until around about 9 months again of age. Adolescents actually do start to see a slight decrease in renal tubular clearance as well. So it's obviously worthwhile, and when you do start to see your sort of 12-year-old children who are perhaps prescribed certain medications and you're watching over them, just keep an eye out and just to see if there's any changes that are happening with adolescents. The intestinal activity of cytochrome P450 does differ with age, so drugs are bioavailable and they're absorbed differently. So for example, phenytoin, elimination half-life is 75 hours at birth, whereas it sort of gets down to about 8 hours by 14 days of postnatal age. Theophylline as well is something else that we have to really be careful of with neonates. So the half-life can be really quite high, about 8 to 18 hours after birth, whereas by 48 weeks of life you see it's sort of down to about 3 or 4 hours, which is the same as the adult sort of rates. Neonates, you'll notice that they break down paracetamol a different way as well. So they break down paracetamol as sulfontoin rather than glucuronidation. So that actually does make a difference. Nephrogenesis is still occurring in the neonatal period, so that you know, everything's still, the glomerular filtration rate is still developing from preterm all the way up to infant levels. So drugs can build up over time. Drugs can be more toxic and stay around the system in neonates, and that's the most important factor to note about metabolism and excretion in this slide. So when you're dealing with a neonate, you might well have significantly more risk of toxicity. One thing that we do to be able to correct that is to start to give drugs over longer periods of time. So we give them 12-hourly dosages as opposed to you know, 4-hourly dosages, or we might even consider 18-hourly doses for things, you know, like theophylline, for example. And we would do serum testing as well to make sure that we weren't building up any levels that might become toxic. Because again, if you're dealing with a neonate, you've got a more prolific blood-brain barrier, you've got less ability to be able to get rid of drugs, you've got a higher affinity for damage and a smaller body as well. So how do we give drugs to children, to babies and to adolescents? Same way as we do for most people, most adults as well. So first one is intramuscular. Of course, there you've got needle phobias, you've got in a neonate, you've got lack of adipose tissue, so you've not got the muscles sort of and the lovely sort of fat layers that you would have for as you would for an adult. Oral routes, we've talked about the impaired gastric emptying and the acid environment and the reflux issues that we might well have. IV circulation there is quite marked, so if you're trying to put an IV cannula in a neonate who's just 450 grams, it's pretty complicated. Equally, you've got the access, you've got pain, you've got all the other responses as well. If you have to put an IV cannula into a baby, the parents don't like it. So, you know, make sure that you only use that as last ditch attempt. Rectal administration is interesting. So you've got hepatic metabolism is going to affect your sort of rectal absorption there. Equally, as soon as you start to put anything in a neonate or a child's rectum, they're going to start to there's a risk of expulsion there with rectal contractions as they push against you. Percutaneous, so increased skin absorption. We talked about the increased skin absorption in neonates and children. And here we're looking at as well that the body surface to mass is increased in neonates, infants and children. So we tend to prescribe by centimetre squared for skin absorption and skin prescribed medications. One thing to note with inhalation is that infants are nose breathers less than 3 months gestation, 3 months old. So you have to be really careful with this, because if you're thinking about offering nasal drops to a neonate and the only mechanism of breathing that they have is through their nose, not through their mouth, they're going to start to feel like that it's very uncomfortable for them. If you covered a neonate's nares, they would stop breathing. So it's really important that you make sure that you can take that into consideration. So if you are administering inhaled medication to a neonate, you would put the mask over the mouth and the nose to make sure that you were administrating that drug effectively. Just a note on patient group directions. This is something that we have in the UK. So things like immunisations, for example, which are given, it's written direction relating to the supply and administration of licensed prescription-only medications by certain classes of healthcare practitioners to a number of different people. So I'll just leave this here for you to have a read of. Things that I always raise, and it's difficult just doing this as an online lecture, because I normally sort of get people to start talking about their own experiences, but things to note: female adolescents are of childbearing age, so always have a think about birth control, effects of illness. So if your adolescent female comes to you with diarrhea and vomiting, you need to be thinking, is that going to affect the pill? Is that going to affect sexual health issues? What alternatives do you have? There's also a number of studies that identify peer pressure does affect adolescents as well. So we tend to see a slightly lower compliance in adolescents who are taking medication for regular conditions, cystic fibrosis, epilepsy, diabetes and asthma. You do tend to find sometimes, or there have been studies that have linked lack of concordance and conformity with prescribed treatment regimes during the adolescent period. So with this one, it's just about working with your patients, talking to them on what the best strategies are to be able to encourage concordance with medication. And speaking as a mum of 3, one of my most important slides is just have a think about the additives that are in the medications that you might be giving. Many drugs have additives and they're there to be able to preserve the life of the substance. They can affect your paediatric patients. We've talked already about use of alcohol to wash a site before you start to do a procedure and how that can cause toxicity and absorption in the neonate because the skin's so thin. Also beware about the hepatic clearance as well. So they're going to be absorbing the alcohol a lot more readily, but they're also going to be retaining the alcohol a lot more readily as well. A number of medications are now available on sugar-free sort of alternatives. But I don't know if you've ever tried to have some of the antibiotics which are sugar-free, but they're horrendous. One of the other things to consider as well is the laxative effect of some of the sugar alternatives, and that could potentially have an effect on your child or your neonate or your adolescent. Some of the things we have to think about when we're administering IV medications with neonates specifically or children is how much sodium can be used as the additive, so that can cause your hypo or hypernatremia, and also dehydration as well. That's going to cause a problem. There's many food dyes that can cause ADHD type or hyperactivity or whatever else type sort of effects in some of the children. There are some preservatives that do just the same, and just remember that sorbitol is also a laxative, so if you're giving sorbitol containing medication to some of your children and babies, just be aware that mums might not be too happy about all the extra changes of nappies. The most important thing to consider when you're prescribing for children is just add a bit of common sense. Children grow, which means their weight fluctuates, so weigh them at every visit. Only ever prescribe medications for the weight that they are. If they actually get to adult sort of levels as well, don't start increasing the dose because the weight's increased and is higher. Don't go above the usual adult dose if you're ever going to be working out milligrams per kilogram sort of dosages. Always round up drugs as well. If their parameters mean halving tablets or administrating, something like 0.02 of a mil of medication, try and round it up. Try and make it easier for the parents to manage. Think about how you would feel if you hadn't slept for 50 nights on the trot and you were trying to give a child in pain 0.02 mils of a particular medication. Have a think about what's easiest, what's the most effective, and how are you going to encourage concordance and compliance, not just for the child but for the mums and dads as well. We don't want to be waking the babies up to give them medications unless we really need to. So think about administration times as well. Do they fit in with schooling, bedtime, other factors? What are we expecting our parents to do? Do they understand how to clean out the spacer devices or whatever else that we're going to be giving them to be able to help them to administer medications? Think about all the stuff that we need to consider ourselves when we're delivering these medications, and teach the parents and the grandparents and make sure that you've got everybody on board to be able to assist with concordance and compliance of medication administration in neonates, paediatrics and children. More tips. Always make sure that you offer a measuring device as well. So, if you're going to be giving parents of a child a syringe, do they know how to use it? How do they work out what 2 mils is, what 10 mils is? Are they going to make sure that they've got the right part of the syringe to be able to measure that dose? Make sure that your parents and your patients know exactly how to use their equipment and they know how to clean and manage their equipment effectively. And if there are any allergic reactions and any issues with drugs, please make sure that you report it to the Medicines Healthcare Regulatory Authority Yellow Card Scheme. And make sure that you describe any potential reactions and potential issues that might happen, not just to the parents, but to all caregivers that you actually do speak to. And absolutely, essentially, reinforce that drugs are not for sharing between adolescents and children and whoever else. So I hope this session, it's just a basic session on prescribing for pregnant, breastfeeding, and in children paediatrics settings. I hope this has been a very, very basic, easy, understandable sort of quick overview for you all. Please feel free to contact me if you've got any questions. I'm available on a.j.lee@hull.ac.uk, and there's a couple of references that I've included throughout the series as well, to be able to give you an idea about where you can go for further references and further readings. Take care.